regarding the non-muscle invasive bladder cancer, and Sir Gaurav sir will discuss regarding the BCG refractory. So, sorry, I have not prepared the slide, but I will discuss what I in day-to-day life in practice I use to follow the things. Most of the time, I have seen the bladder cancer is the first epidemiology. The worldwide bladder cancer is 7th most common cancer. So, so the incidence over here, I have working here since the last 4 months. So I have seen 8-9 patients just in 3 months, operable patients. We have sent for NSAT. We have operated 3-4 patients also here. So there is a burden of bladder cancer over Muzaffarpur here also. So generally the patient will present to me with the symptoms of painless hematuria. The most common symptoms is painless hematuria. Around 85 to 90% of the patient has painless hematuria, followed by other symptoms like bladder irritative symptoms. They present with that. So how I evaluate those patients? The basic blood investigations I used to send. Then after, first I will come to this cystoscopy. So for diagnosis, we need a cystoscopy. Cystoscopy is important to give a diagnosis, to tell whether it is a muscle invasive or non-muscle invasive. So first, if it is a non-muscle invasive, then cystoscopy is the way to treat it, followed by whether we will give mitomycin or will give BCG. That depends, that has been discussed. So one thing is cystoscopy, and whenever the patient suppose comes with the non-muscle invasive bladder cancer to us, so I preferably follows after 2 weeks, mostly within 2 to 6 is the week is the limit when we used to repeat the cystoscopy. But I usually prefer after 4 weeks to have a repeat check cystoscopy and whether the muscle invasion is there or not. If around 15 to 25% cases there is upgradation, we will have muscle invasion or vice versa. Whether sometimes, but 25% cases there will be chances of having high grade high grade or muscle invasive tumor in non-muscle invasive bladder cancer. So the cystoscopy is very important. Second thing that sir has asked about the role of field catheterization. So the field catheterization that will change the management. Sometimes if there is multifocal or if field catheterization, we are suspecting field catheterization. So sometimes if it is lesion is in trigon or the VUC junction, so I would like to prefer, and on a scan, if there is some lesion in the pelvis, renal pelvis or in ureter, I would like to go for check ureteroscopy also. There is 2 to 4% chances that the tumor will involve the ureter, renal pelvis also, and the management will change. In that case, we will need radical nephroureterectomy also with the cystectomy. So in those conditions, I would like to do this ureteroscopy also. Now, this was a cystoscopy. Cystoscopy will give us the diagnosis. Then after, it is muscle invasive. The next thing is urine cytology. Sir has discussed high grade tumor. There is 85% of chance that will be the urine cytology will be positive. In lower grade, there is 15% chances that cytology is positive. But it is negative, it will not rule out. It is one more evidence to support there is a tumor. Second, cytology, and we'll see the urine routine culture also, just to rule out any infection component is there or not. Now for staging, we'll do CCT. Okay, so CCT we used to prefer the CCT thorax. Generally, abdopelvis is sufficient, but in 2 to 4%, 5% cases, there may be just to rule out any thoracic lung mets also. So now come whether we need MRI. Sir has discussed everything regarding that, the MRI, concept of MRI. In Tata, we don't use MRI. Just MRI, what is the role of MRI here? MRI to distinguish between whether it is a muscle invasive or non-muscle invasive on basis another condition apart from that TURBT. So right now we are not following the MRI to distinguish between. Generally, MRI used to distinguish. Now, in one thing in cystoscopy, I would like to add. the prostatic biopsy. The importance indications of prostatic biopsy. Sometimes there may be the condition of vice versa, prostatic tumor, so infiltrating the bladder also, bladder neck tumor. In that conditions, we will use, or if the PSA of the patient has been elevated, in these three conditions, I would like to go for prostatic biopsy also with TURBT. Okay. So all these will give a diagnosis, then it will give a staging to me. If it is all the patients above T2, transitional cell cancer, and I would like to prefer to send for NSAT. There is a 5 to 8% survival advantage over 5 years of giving GEMCs to these patients in muscle-invasive cancer patients. In other, suppose it is a squamous cell or it is sarcomatoid, so it's not chemosensitive, so it's better to go for upfront radical cystectomy rather than giving NSAT. So after NSAT, after giving completing GEMCs, sometimes we have to check whether the patient is, if it is not chemo means eligible, then we have to go for upfront cystectomy, radical cystectomy also. So after after chemotherapy, after 4 weeks, I generally used to prefer to have a check scan once again, CT tap thorax, and will evaluate the patients. And if it is operable, how I manage the patient. First, I will look the general condition of the patient. Most of the bladder tumor that I have seen, they presented to us at the age around 70, 65 to above. That in last what I have seen here. So first is whether the patient is having any comorbidities or not, or whether the patient is fit for the surgery or not. First, fitness is very important. Otherwise, we have to offer another option. Just like the radiation therapy, the option will come. He will discuss regarding that. After that, the comorbidities, all these things will come in the evaluations. Second thing is spirometry, and the nutrition is very important for the patient because the surgery is a stressful condition, and most of the patient will lie in ward in around 9 to 10 days. So after surgery, and we do the anastomosis. For that, the nutrition is very important for the patient. So what we prefer, we used to give a spirometer and a high protein diet 15 days before the planned surgery. So that helps in our post-op betterment of the patients. Then after surgery, what surgery know better than me, radical cystectomy, and most of the time how I used to do radical cystectomy. First, I used to go for a lower midline. That incision will go just supra above the umbilicus. After exploring everything, what is important that we prefer after ureteric mobilization, we used to prefer doing the nodal dissection first. Then after we used to do the posterior dissection, and then after we used to cut the ureteric margins, ureter. And after that comes the reconstruction part. After posterior dissections, lateral dissections, everything is done, finished, the specimen is out, then reconstruction. So what we prefer here, right now we are doing ileal conduits. So most of the time we are doing ileal conduits, but neobladder can be done if the prostatic, we have to send the prostatic margins, cut margins. If it is negative, we can go for we can provide an option of that neobladder to the patient also. The counseling is very important before surgery regarding that you will have a permanent urostomy bag, urostoma will be there, and it will be a lifelong. So the counseling is very important. And then after the reconstruction, we used to do that ileal conduit. Most of the 3 patients, we have operated 3 patients here. Hopefully all those patients went well. And yes, sir. Any questions I would like to take on? If you want to.
I said, Dr. Santosh sir.
Yes, sir.
There is one situation. there is one situation when during my practice I get yes sir. नहीं, ठीक है. Tumor around the ureteric orifice, left or right, with involvement of lower end of the ureter. No involvement of upper ureter, middle ureter, upper ureter, or renal pelvic system.
Yes, that I understood.
Yes.
Yeah. So,
Just a minute.
yes, sir.
In CT, even in CT, or even after ureteroscopy during resection, what will you do?
Yeah.
What you suggest for that situation?
So, most of time in this situation, I would like to do a DTPS cancer. I will see the function of the that kidney also.
If it is functional.
Yeah. Then, sir, what we practice, we will go for radical nephrectomy, sir.
Radical
Nephrectomy, yes, sir.
No,
Because
no,
of field cat.
Why nephrectomy? Why you are sacrificing the kidney?
Sir, there may be chances. Field cancerization, there will be chances in near future that again the tumor will somewhere develop in the pelvis or the ureter system. So if it is in ureter, involving ureter, it's better to go for.
Lower ureter.
Yes, sir. Even I means what we prefer at Tata.
Yeah, that I know.
Yes.
Can we do ureterostomy and preserve the kidney?
Yes, sir. That we prefer is
Fine.
yes, sir. If any opinion and any data available to anyone,
There
that we
was
can
an
discuss.
interesting thing. I am not a urologist. I know nothing about urology, but there was an interesting thing that you do. That during the surgery, if there is
Yes, sir.
during surgery, if you want to take prostatic biopsy, how do you identify the representative areas from where it has to be taken, and how many cores you take, and what is the modality through which you look at the prostate and take the course during surgery,
During surgery.
during assessment also, when you are doing
Just
a
guided.
prostatic biopsy. That is what I wanted.
Actually, yes,
नहीं, Dr. Swarnim, you go first. You go first.
sir, this is your no, this is your thing, sir. First, you,
Sir has asked you.
No, sir. If we are suspecting prostatic
You are
inversion,
not suspecting it. The lesion is in trigone, then you want to take the prostatic biopsy.
So we do PRBT, like we are that prostate biopsy is different.
That's what I was asking. With PRBT, how you take
Just with the spectroscope,
some bits of
Yes, sir, that
that,
is correct.
that might not
and
be
that
representative.
is a different thing.
Exactly. That is not
These are two different things. One is that while you are doing a TURBT, if the tumor is located at the trigone or near the bladder neck, then there are some recommendations. It's not a universal recommendation that you take a separate biopsy from the parafollicular area at the 5 and 7 o'clock. You just take a pass of the loop and send additional, label them as in an additional thing. That is to just because that will, suppose it turns out to be
adjacent area.
it turns out to be muscle invasive and you are planning a radical cystectomy later, then neobladder will be ruled out. An orthotopic this reconstruction will be ruled out. You have to go for an ileal conduit. One scenario Dr. Swarnim was mentioning was when there is a confusion that whether there is a prostatic lobe hanging at the bladder neck and causing ureteral orifice involvement, or there is a bladder tumor in that location which is obstructing the ureteric orifices. And so the PSA health of my urological career, I have seen
50 patients are coming, but what I have operated in last 3 months, all those were around 70.
I have seen patients of 24 years, 25 years age group, 30 years, 40 years age group with high grade muscle invasive bladder full of tumors, completely full of tumors.
Young and active.
So, what is your suggestion? This is just my comment that what I got in during my practice.
ये ऐसे कितने केसेस देखे हैं
ज्यादा है, young
ज्यादा है ना, तो मे बी ये टोबैको से और लिंक हो सकता है, इतना ज्यादा कंज्यूमिंग
Smoking से है ही।
स्मोकिंग टोबैको गुटखा सब
Sometimes
तो
genetic factors also.
अच्छा, what is your Karnofsky scale cutoff percentage? Karnofsky 60 and above you operate, or
No, sir.
Karnofsky 80 and above you operate?
I generally
For this
80 above,
mutilating
PS1, PS2, 80 above, PS2.
Good, very good.
Thank you.